Hi everyone, my name is Jenna McAlpine and I am the clinical dietitian here at Louis Breyer Home and Hospital and Weinberg Residences. This includes the intermediate care on the first floor, extended care on the second floor, the special care unit, and the multi-level care over in the Weinberg Residences. First off, I'm going to talk about what do clinical dietitians do. Clinical dietitians monitor, assess, and optimize nutrition status based on the resident's current medical condition, nutritional status, and their preference to enhance that individual's life as much as possible. We work closely with the interdisciplinary team to develop a nutrition care plan for each resident, and we rely on them to implement the plan to maintain and to optimize each resident's nutritional health. Some examples of this include assessing the need for modified diet texture through a swallow assessment to observe the resident's ability to chew and/or swallow food and/or fluids. Next is assessing the need for additional snacks, supplements, and vitamins or minerals. And thirdly, another example is assigning feeding plans, introducing feeding technique and feeding aids, for example, soup in a mug or a divided plate. Please refer to me if you notice any residents experiencing weight loss, developing pressure ulcers or wounds, experiencing difficulty chewing and or swallowing, having poor intake of meals frequently, or any other nutrition concerns that may be a red flag for you that you would like to discuss with the dietitian. So next, we're going to move on to dysphagia. So what is dysphagia? Dysphagia refers to the swallowing dysfunction as a result of neurological, behavioral, mechanical, or structural diseases or conditions. Many of our residents have some degree of dysphagia, which can make eating and drinking more difficult for them. So the role of the care staff and the companions is to protect the residents' health to ensure they are safe during meal and snack times. Care staff must know what the resident's nutrition care plan is. So this includes the diet type, texture, any fluid alterations, and any food allergies or intolerances. They also must know what is food safety and how to properly position the residents for the meals. They also must know how to provide the amount of help that the resident needs and alter the help they give based on what the resident is indicating. And also how to pace the meal delivery, because it's important not to feed the resident too fast, but also we don't want it to take too long either, because that also can be detrimental to the resident's health. And then how to make each bite count. And finally, the importance of oral hygiene. So feeding assistance. Residents who are unable to eat independently have an increased risk of malnutrition, which could result in weight loss, dehydration, which could result in constipation and an increased risk of urinary tract infections, fear of eating or drinking because fear of choking, and aspiration, which is fluid or food into the airways or lungs that could lead to aspiration pneumonia. So now we're going to look at diet type. Diet type. Diet is individualized for each resident by the dietitian based on a complete nutrition assessment of the resident's nutritional needs, a doctor's order, and the resident's health condition. Examples of diet types we have here at Louis Breyer Home and Hospital and Weinberg Residences includes regular, diabetic, gluten-free, lactose-free, no salt added, and renal. Then we move on to the diet texture and fluid consistency. Diet, food and/or fluid texture is determined by the dietitian based on the resident's swallowing and/or chewing capabilities. Texture of the food and/or thickness of the fluid is modified to maintain a normal nutrition and hydration status while reducing the risk of aspiration and choking. Available food textures are regular, soft cut up, minced, and pureed. The available fluid textures we have here are the regular, which are the thin fluids, nectar thickened, honey thickened, and pudding thickened, with our most commonly being used is the nectar thickened. So it's important now that we know about the different types of feeding textures and fluid textures that we go on to the proper feeding technique so that the residents are getting the proper food they need in the proper way. First off, I'm going to look at the correct resident feeding position for when a resident is seated. Ensure before you start, dentures, glasses, hearing aids as needed are in and on. and that if a resident is in a wheelchair, that the brakes are on. Hips are placed at the back of the chair, both feet are supported, trunk is stable and upright, and if the resident is in a tilt chair, bring it to the most tolerated upright position. Make sure the head is at the best possible neutral position. Chin can be tucked slightly downward. Next, we're going to go to correct positioning for feeding in a bed. This is where we want to make sure the residents are at the right angle to prevent any chance of choking or aspiration, as it is a high risk if a resident is fed at an angle that is not sufficient for feeding. So first off, we want to elevate the feet of the bed to a 10-degree angle, and then the head of the bed up to at least 70 to a 90-degree angle as tolerated. Support the resident in an upright position with bolsters and wedges. Refer to the rehab poster above each resident's bed to get information about what bolsters and wedges are required for that resident. Head is in a neutral position and chin is tucked down. Residents must stay upright for at least 45 minutes after eating or drinking to help aid in digestion. Next, after focusing on the position of the resident at both sitting and laying down, we also want to look at the feeder position of the care team or companion who is feeding this resident, which is just as important. The feeding position. The dining experience should be enjoyable, a social opportunity, and comfortable. As the resident's caregiver, you can promote this experience by, first off, being at the resident's eye level. Sit down. If the caregiver is seated or below the eye level of the resident, it allows them to ensure the resident's head is at a safe, neutral position for swallowing, and allows them to see the resident's reaction to the type and amount of food being offered. It also allows them to see or feel when a resident has swallowed before offering another bite, because it's important to make sure that resident has completely chewed and swallowed their food before offering another bite, as if you offer another bite too quickly, it could also cause choking. On top of that all, it allows the person feeding to share social interaction with the resident. So making eye contact, engaging in conversation with the resident, watch for the resident's facial cues. This allows you to adjust mouthfuls and do not force feed. For a resident who is blind, you can assist by describing where the food items are on the plate, using modified utensils such as a divided plate or soup in a mug, speaking in a calm and pleasant voice, and if feeding is required, wait until the resident is ready, then cue him or her the spoonful is coming. Also, for residents who are blind, you can help assist them with hand-over-hand feeding if necessary. So next, we're going to move on to eating aids. There are many modified dishes and utensils available to help residents eat independently. Some examples of these are weighted cutlery to reduce hand tremors, built-in handles for an easier grasp, and the use of a teaspoon if a tablespoon is too big, or when in doubt. The occupational therapist and rehab team will be able to advise which may work best for your resident. So next we'll move on to how to choose nutrient-dense foods. These are for your residents who could be at risk of malnutrition or their weight is dropping and we want to prevent that weight loss and maintain that weight, and an ultimate goal of promoting weight gain. Some things that you can do for this are choose foods rich in protein first. So this would be the meat, cheese, eggs, poultry, fish. And then another thing that we can do is add more sauces such as gravy, sour cream, full fat condiments like butter and margarine. Also offering the resident, or if you're feeding them, serving the main entree first, as it often provides more calories and nutrition than the other parts of the meal, and then feeding the other parts of the meal next. Also serving the milk and juices before the water, coffee, or tea. The water, coffee, and tea provide minimal calories, and the milk and juice will provide some excess calories for that resident. Next, we want to look into the importance of a clean mouth, as this is crucial. It is important to brush or clean the mouth after each meal, even people without teeth. Bacteria builds up in the mouth and can be aspirated into the lungs when the teeth and gums are not clean. Many folks cannot undergo frequent dental cleanings due to general anesthesia needs, so bacteria often will build up. Food can pocket in the roof of the mouth and in the cheek area. This can cause a later choking event. So that's why it's so important that we focus on oral care to prevent the buildup of bacteria and food being stuck and pocketed in the mouth, which could later be choked on. All these examples clearly highlight the importance of adequate oral care. Now to summarize what we've gone over. So it's important to ensure both you and the resident are in the optimal position during mealtime. This is the position of both yourself and the resident. And to notice the difference of feeding between a resident who is sitting versus a resident who is in bed. Next is to communicate and interact with the resident at an eye level. And lastly, to ensure the environment is appropriate to create a positive experience with the resident, as mealtime is a time that should be enjoyed for everyone. Always ask the dietitian, occupational therapist, or rehab team if you have any further questions or concerns. Thank you.